Welcome to Clinical Tools Library, evidence-based scales and questionnaires designed to support healthcare professionals in practice. The National Institutes of Health Stroke Scale assesses neurological function in patients experiencing acute ischemic or hemorrhagic stroke. It evaluates key domains such as level of consciousness, language abilities, motor strength, sensory perception, visual fields, and ataxia. The scale quantifies the severity of neurological deficits by scoring each domain on a standardized scale. Its main purpose is to facilitate rapid and objective assessment of stroke severity to guide clinical decision-making and monitor changes over time. The scale also aids in predicting patient outcomes and eligibility for specific interventions, such as thrombolytic therapy. The National Institutes of Health Stroke Scale is indicated for adult patients presenting with acute ischemic or hemorrhagic stroke symptoms. It is most useful in the initial clinical assessment to quantify neurological deficits. The scale aids in determining stroke severity, guiding treatment decisions such as thrombolytic therapy, eligibility. It is also employed in monitoring neurological changes during hospitalization and predicting patient outcomes. The scale has demonstrated high inter-rater reliability and validity across diverse clinical settings, including emergency departments and stroke units. Its use is less validated in patients with pre-existing neurological impairments or altered consciousness unrelated to stroke. The National Institutes of Health Stroke Scale consists of 15 items that assess various neurological functions. The examiner begins with level of consciousness by asking 3 specific questions and commands. Next, orientation is tested by asking about the patient's location and date. Following this, commands such as opening and closing the eyes or gripping and releasing the hand are evaluated with binary response options indicating normal or impaired function. Visual fields are assessed through confrontation techniques to detect any deficits. Facial palsy is scored based on symmetry during smiling or grimacing. Motor strength is tested separately in the arms and legs by rating the ability to hold limbs against gravity, with scores ranging from normal to no movement. Limb ataxia is checked by observing coordination during finger-to-nose or heel-to-shin tasks, and rated as absent, present, or not testable. Sensory examination involves assessing response to pinprick stimuli with options for normal, mild, or severe sensory loss. Language skills are evaluated through naming, sentence repetition, and comprehension tasks scored from normal to mute. Dysarthria is rated based on speech clarity during articulation tasks. Neglect is assessed through extinction and inattention, testing on double simultaneous stimulation. Each item uses a structured scoring system with ordinal scales defined from 0 to a maximum value specific to each domain. The total score ranges from 0 to 42, with higher scores reflecting greater neurological impairment. Scores from 0 to 5 typically indicate minor stroke, 6 to 14 suggest moderate stroke, and scores above 15 are indicative of severe stroke. These established thresholds aid clinicians in determining stroke severity and guiding treatment decisions. The sensitivity of the National Institutes of Health Stroke Scale in detecting acute stroke ranges from approximately 75 to 90%, indicating that it correctly identifies 75 to 90% of patients who truly have a stroke. Specificity varies between 60 to 85%, reflecting the scale's accuracy in correctly excluding individuals without stroke. Sensitivity measures the test's ability to detect true positives, minimizing missed cases, whereas specificity assesses its capacity to identify true negatives, reducing false alarms. For example, a sensitivity of 85% implies that out of 100 actual stroke patients, 85 will be correctly identified by the scale, while a specificity of 70% means that 70 out of 100 patients without stroke will be accurately classified as negative. These metrics guide clinicians in interpreting National Institutes of Health Stroke Scale scores for timely and accurate stroke diagnosis. The National Institutes of Health Stroke Scale was developed in the mid-1980s by the National Institutes of Health Stroke Data Bank to provide a standardized method for assessing stroke severity. The validation of the scale involved a cohort of acute stroke patients whose neurological impairments were systematically evaluated and correlated with clinical outcomes. Initial studies demonstrated that higher scores on the scale corresponded with increased stroke severity and poorer prognosis. Subsequent research conducted by Brott and colleagues in the early 1980s established the scale's reliability and inter-rater agreement, showing a kappa statistic of approximately 0.8 for overall scoring consistency among trained examiners. Further validation efforts included prospective studies by Goldstein and colleagues that confirmed the scale's capacity to predict infarct volume on neuroimaging and functional outcome at 3 months post-stroke. Meta-analyses have supported the scale's sensitivity to clinical changes and its utility in both clinical trials and routine practice. Collectively, these data underpin the widespread adoption of the National Institutes of Health Stroke Scale as a valid and reliable instrument for quantifying stroke severity. Thank you for watching. For complete information and official PDF resources, visit clinicaltoolslibrary.com or check the link in the description below. And don't forget to like and subscribe for more clinical insights.